Thank you, everyone. We will now begin the afternoon scientific session. To chair this session, may I invite Dr. Samanmali Dalpadatu, Chair of the Airway Assembly of the Sri Lanka College of Pulmonologists and Consultant Respiratory Physician, National Hospital for Respiratory Diseases, Velisara, to kindly come forward and take her seat on stage. Over to you, madam.
It's a pleasant task to complete today's final segment of this bronchiectasis session. So I think we have in the third segment. So I think the name says bronchiectasis 360-degree turn. So now it's 270 completed. So it's not just a 90% remaining. So isn't it? So the third segment, the first lecture. So as a physician, we frequently encounter tuberculosis and bronchiectasis, but non-tuberculosis mycobacterial disease remains mystery even for today. It's relatively uncommon and challenging. Species identification is not always possible in our country. So not patients require treatment. So this NTB needs some experts' opinion for our bronchiectasis day to day. So it is pleasure to welcome Professor Michael Lobinger, the consultant respiratory physician who is a world-renowned consultant in bronchiectasis. So he is a professor of practice in respiratory medicine at Imperial College, London, director of the lung division, and clinical director of the laboratory medicine. He is a deputy medical director and consultant in respiratory medicine, Royal Brompton and Harefield Hospital, Guy's and St. Thomas's NHS Foundation Trust, United Kingdom. Internationally, he recognized for respiratory physician with expertise in bronchiectasis, chronic respiratory infections, non-tuberculosis mycobacterial disease, primary ciliary dyskinesia, TB, and primary immunodeficiencies. He is co-chaired the British Thoracic Society Guidelines for Bronchiectasis and co-authored the European Respiratory Society Bronchiectasis Guideline and the British Thoracic Society Non-TB Disease Guideline, making significant contribution to the international clinical practice. So we'll listen to the lecture on non-tuberculous mycobacterial disease now.
Hello, I'm Michael Lobinger. I'm sorry I can't be with you. I'm from the Royal Brompton and Imperial College, and I'm going to speak to you about NTM management. There are my disclosures. So, as you know, NTM are mycobacteria that aren't TB and aren't leprosy. They've been documented for many decades now, and as time goes on, the number of species that are identified increases. But a relatively minority of them are actually pathogenic to humans. They are spread by the environment, so by rivers, by water, by soil, by showerheads potentially. And the most common manifestation, and the one that I will talk about in this talk, is pulmonary manifestation. And these bugs are everywhere, and hence there needs to be an interaction between the host and the susceptibility of the host and the microbe and the exposure to it, which I will talk about a little bit as things go on. So the prevalence isn't exactly known. This is a relatively recent study which looked at publications from different areas of the world, and you can see that from that the prevalence globally is somewhere between 1.5 and 40 per 100,000. What we do know, however, is that the prevalence seems to be increasing worldwide, and this is demonstrated by the graphs on the right-hand side, which show trends in Germany increasing. The middle one is Japan, with the line going up being NTM and the lines coming down being smear positive and culture positive TB, and the one at the bottom being our own laboratory cultures over the last couple of decades or so. And the annual increase has been put somewhere between 3 and 8% per year. And again, similar to the previous graph, this is a meta-analysis of multiple studies showing that in the majority of them, the majority of studies show an increase in in prevalence rates over different countries. So, who gets it? So I mentioned right at the beginning that these microbes are everywhere, and hence there needs to be some kind of interaction between the host and the microbe. So let's have a look at both of these sides. So firstly, exposure. We know that where you live can increase or decrease your susceptibility to NTM, and this is some work from Rebecca Prevost's group, and you can see that the prevalence increases in different states of America, and it is related to the humidity of that state. So you can see particularly high prevalences in California, in Florida, in Hawaii. And also, it's not just where you live can increase your chance of getting NTM, but where you live can also increase or change your exposure to different NTM species. And this was from a decade or so ago now from Wouter Hausflut's group. And you can see this is just essentially an audit of different laboratories around Europe showing the prevalence of different species. And you can't obviously read all the different things here, but suffice it to say that the blue in the pie chart is MAC, which is the most common around the world. Now, what you do in an area can also increase or decrease your chance of getting NTM. I'm not sure if a picture of me is blocking the second panel, but this is really just meant to show that that in one study from 2011, soil exposure, but not water exposure, was more common in bronchiectasis patients with NTM compared to bronchiectasis patients without NTM. But that this relationship didn't hold in healthy controls, again, showing you a likely mix between exposure and susceptibility. And the panel on the right relates to swimming, which showed that CF patients were more likely to have been indoor swimming in the 4 months prior to an NTM culture than CF cases without NTM. But in those studies, only less than 10% went swimming in both cases. And this is really the issue with case control studies, in that often the environmental exposure is similar to both. There's issues with the incubation period, recall issues, spatial analyses have therefore been done instead. And this change in the map of America is an example of a spatial analysis where instead of states, you can see down to actual towns the change in prevalence of NTM. And there it relates to various different things such as water tank isolation, and also soil composition such as magnesium in the soil, and those kind of things which can increase the susceptibility or the exposure to NTM. So let's now have a look at the other side of the coin, which is the host. And we know from previous studies that having chronic lung disease can increase your chance of getting NTM or your susceptibility to NTM, and it's about 10% in bronchiectasis, CF, PCD, also increased in COPD in various studies. Age, immunosuppression, and morphology relates to patients, particularly with middle lobe and lingular NTM, or nodular bronchiectatic type of NTM, and that was reported many years ago by Prince, and has been called Lady Windermere syndrome in the past. Now, we did on the right a meta-analysis of all these studies that we published a couple of years ago now, which showed the same kind of things. You can see the increased risks for chronic lung disease. Also in there you have inhaled corticosteroids, tumours, use of anti-TNF treatment, etc. There was no increased risk, however, found by taking a macrolide, although obviously you need to be careful taking a macrolide as a sole drug if a patient has NTM. In fact, you shouldn't use that as a sole drug. Okay, so these are the patients that you should think about testing, the patients that are at risk of susceptibility. What do you do when you get a positive culture? Now, because these microbes are ubiquitous, which is something I've mentioned a few times, a positive culture is not that unusual, and it can relate to a contaminant, a casual isolate, i.e. once but never again. It could be related to colonization or actual pulmonary disease. Now, how to separate those out? We use the ATS guidelines, And in order to get rid of contaminant and casual isolate, you need the microbiological criteria, which is 2 of the same species from 2 cultures, or from a protected culture like a biopsy or a bronchoscopy. And to get rid of colonization, you also need evidence of disease by symptoms and radiographic change on a CT scan. What do I mean by symptoms? So these are the kind of symptoms that we would expect: cough, sputum, hemoptysis, maybe some systemic symptoms like sweats and fevers, weight loss. But a lot of these symptoms can be difficult if you have the respiratory comorbidity of bronchiectasis, for example, and hence you may be looking at change, so deterioration of a patient with bronchiectasis, and also annual surveillance in those patients as well. These are the type of radiographic changes we'll be looking for: tree and bud, and you can see there actually a tree and bud, and that on the top left-hand panel, there's some tree and bud there that you can see in the left base, together with some bronchiectasis, with the other panel showing some of the other features mentioned there. Okay, so once you've made your diagnosis, you've decided to test your patient, you've got 2 or more positive cultures, you've got evidence of disease by those criteria, what should we do? Should we treat all those patients? Well, it's not as simple as that, and I've got 3 very quick cases to illustrate some of the complexities with regards to decision making of when to decide to treat. So the first is a 45-year-old lady, idiopathic bronchiectasis, and exactly what I described: starts doing worse generally. She has a CT scan, and for those eagle-eyed amongst you, the changes in the left base are exactly the same as the top left-hand panel, so would be certainly consistent with NTM. And in fact, she grew NTM, so she grew Pseudomonas and cultures of NTM. But in this case, actually, we first decided to optimize her bronchiectasis. We treated more aggressively the Pseudomonas, optimized the physiotherapy, and in this case, everything got better, and you can see that in the CT panels. So this is case 1, which is no NTM treatment, despite reaching all of the criteria for NTM pulmonary disease. How about case 2? Well, case 2 is a 34-year-old Italian chef, presents with a 2-month history of acute symptoms and quite marked changes with cavitation on his CT scan. And for him, we immediately started treatment for MAC with rifampicin, ethambutol, and azithromycin, and you can see significant improvement. And he had 12 months of treatment following sputum conversion. He had remained well, and here's case 2, again featuring all the factors for NTM pulmonary disease, but here's immediate and successful case of treatment. Final case. Case 3, 72-year-old, history of previous pneumothoraces, background of COPD, and like the first one, starting to do less well. Has a CT scan, pretty much like the second, with cavitatory change, grew Haemophilus, and Mycobacterium chelonia. What did we do here? Well, again, I didn't immediately treat. I also started looking for other causes, found him to have evidence of semi-invasive aspergillus disease or chronic aspergillosis, and actually started treating this rather than the mycobacteria. So this is case 3. Again, would have enough to go for NTM pulmonary disease, but this is alternative diagnosis. So what is the difference here? Well, in each of these, if somebody has disease, before I start treating, I have a think about extent, progression, significance, and the patient. And the second one was an example of extensive disease. So there they had evidence of being unwell with cavitatory lung disease, and we know that these patients do less well. All of these features listed here are factors related to a poor prognosis, so that's why we started treatment immediately. Case 1 was not extensive disease, and here I'm looking for progression. So this happens with quite a lot of patients, whereby actually I follow them over a period of time, looking for changes in their clinical state, in their microbiological state, and in their radiological state. Of all of those, for me, radiology is most important. Progressive radiology with ongoing culture positivity is normally something that would make me be more likely to treat. But actually in the first case, they didn't have progressive changes, they actually had improving changes, and that's why we didn't treat. Now, why didn't I treat the third patient? Now, the reason I didn't treat the third patient is because I have different thresholds for treatment depending on the organism. And you can see here, this is work done by Matej Jankovic from Croatia, but has been repeated elsewhere. And this is just again an audit showing the likelihood for the different species of treating in Croatia. And you can see that it's particularly high in organisms such as MAC and abscessus, but almost never treat in some of the organisms such as Fortuatum, Chelonia, and Gordoni. And Chelonia was one of the ones that often isn't pathogenic, and hence, in that last case, I had a much higher threshold for treatment. So before treating, I went on and looked for other things, and hence decided to treat for the Aspergillus. And then finally, the patient. As we will go on, these organisms are not easy to treat. There's a lot of medication and a lot of problems with medication, and hence dependent on the comorbidities of the patient, whether they can tolerate drugs, what their preference is, and often it's a discussion with the patient, and treatment goals. So sometimes treatment goal will be cure, but it won't always be. So sometimes cure would be unlikely, and actually then you need to have a think before you start treatment, what are we actually trying to do here? Is it stability? Is it symptom improvement, etc.? And we don't always treat, so often we do follow patients over a period of time, and this is something which is done the world over. This is a nice study from Korea showing that of 420 patients, they didn't treat 93 of them, and actually the success rate of people that converted within that group was about 50%, which isn't that different to the group which I will show you when we start treatment. So if you decide to start treatment, how do you do it? Well, treatment is normally based on guidelines, which is either the Combined Society guidelines or the British Society guidelines, which are both pretty similar. Essentially, I'll talk about MAC here, but it goes for the majority of the NTMs apart from abscessus, and it's a backbone of rifampicin, ethambutol, and azithromycin. For less severe non-cavitary disease, the American guidelines suggest that it can be used on alternate days, although for all of our patients, I normally try to start daily treatment. And there's a consideration when it's cavitary disease whether to start with amikacin at the beginning as well. But despite that, there is a significant unmet need. We know that there is refractory disease. So with MAC, there is a 1,500 patient meta-analysis, systemic review, and the sustained culture conversion is about 60% in that group. And it can be less in others, such as abscess, as I mentioned before. The one which does much better is Kansas-eye treatment. There's also significant drug intolerance that I've alluded to before, and actually I've been part of a consensus group looking at different alternatives that you can have if you have intolerance to particular drugs, and I've shown the paper there on the top right. Even if you do get rid of it, relapse and reinfection can be high. There was one study suggesting it could be almost 50%. I don't think it is that high. I think it's about 20%. And mortality can be significant, up to 40% in some studies, with a graph on the right being MAC and about 30% 5-year mortality. So on the background of that, there have been some randomized controlled trials. The first was the CONVERT study, which is what this slide references, and this was for refractory MAC. And basically, patients could be entered into the study if they were refractory, i.e. they were still culture positive after 6 months of guideline-based therapy. And then, as you can see from the graph at the bottom, there was a 2-to-1 randomization, and patients were either given Arikayce in addition to their guideline-based therapy, or they just continued on guideline-based therapy. The primary endpoint for this study was culture conversion at 6 months, and culture conversion was actually defined by having 3 negative cultures, i.e. negative at month 4, at month 5, and at month 6. And so it's quite a high bar to hit, given that a lot of these patients had already been positive after multiple different drugs before entering the trial. It was a positive study, and the primary endpoint was hit. So 29% of patients in the Arikayce arm had culture conversion at month 6, compared to just under 9% in the control arm. By month 12, that was 18% to 3%. And then by 3 months off all treatment, it was 16% of patients remained culture negative in the ARICASE arm compared to no patients in the control arm. So what I would normally tell my patients is that are refractory is if they go on to ARICASE, they have about a 30% chance of becoming culture negative, and of those, about 50% of them will then go on to remain negative off all treatment. And in view of this study, it became a licensed drug and is actually also in the guidelines, the American Combined Guidelines, to be used for refractory disease. More recently, there has been the completion of this second randomized controlled trial. Again, this was sponsored by Insmed and is again the same product, ARICASE, the nebulized amikacin. However, on this occasion, it was for the start of new therapy. So the patients that were randomized into this treatment were adults with newly diagnosed or newly treated MAC lung disease who hadn't had treatment. And they were randomized either into an arm with this nebulized product together with azithromycin and ethambutol, or a placebo nebulizer together with azithromycin and ethambutol. And there were just over 200 patients in each arm. The primary endpoint for this study was not culture conversion, but it was a patient-related outcome measure. So it was the change in respiratory symptom score, which is part of the QOL-B, at month 13, which was 1 month after treatment. And this was part of an FDA requirement, whereas there were some select secondary endpoints, with one of the most important ones still being culture conversion, again at month 13, 1 month after treatment. So that was the trial. And just a little bit more about, as I mentioned, the respiratory symptom score. This is derived from the QOL-B and consists of 8 questions, as you can see on the right-hand side. And this was after the sputum culture question had been removed. And again, that was part of discussion with the FDA. This also was a positive result. You can see with the primary endpoint here, there was a significant difference between the comparator arm and the arm that was also given liposomal amikacin, or ALICE, and the ALICE arm also had a improvement in the respiratory symptom score above the minimally clinically important difference. So that was the primary endpoint. There was also a positive outcome with regards to the culture conversion at the various different time points. So at 13 months, which was the main secondary endpoint, in the ALICE arm, there was 82.4% culture conversion compared to just 55.6% in the comparator arm, as you can see there. So, also an interesting result with regards to possible different treatment options going forward. And then just finally, in the last minute or so, just to talk about very quickly other types of treatments that have been looked at before. So clofazimine has been looked at in the context of replacement for rifampicin, or actually just reported as a monotherapy, which seems to have some effect, showing it might be a useful drug. Bedaquiline doesn't have much evidence for it, in fact, but is often given to patients with refractory disease. Linezolid is something also given, but again, there is no evidence for that in the literature. Amadacycline is something predominantly used for Mycobacterium abscessus, which isn't something we've discussed predominantly within this talk. Phages has some potential, although has been used in case reports only and predominantly for non-pulmonary disease. Immunomodulators, so trials on interferon gamma, they have not been done for many years now, and did not have positive results, but there was lots of problems with trial design. GM-CSF was a nebulized product, again related to host defense, which had similar results for refractory disease of 29% culture conversion to the study I've just shown you from Convert. And there is also some early data potentially showing nitric oxide may be useful. So I hope that's useful. I hope I've shown that NTM is increasingly important. It's been shown within bronchiectasis to affect up to about 10% of cohorts. So it's definitely something that you'll come across for those testing for it, but not all need treating. And I hope I've given good examples of where treatment might be needed. We've discussed the various treatment options and the guidelines, and also some of the new trials that have been published or not yet published, and some of the other treatments that are sometimes used for refractory disease. Again, sorry I can't be with you. Thanks very much.
So it was a very insightful, informative lecture on very rare disease. So I would like to extend my heartfelt gratitude on behalf of the Sri Lanka College of Pulmonologists. Professor Michael Lobing is not able to present for a question and answer session.